I'm very excited today for our speaker, Dr. Portenoy. He's the Executive Director at MGHS Institute for Innovation in Palliative Care, Chief Medical Officer for their Hospice and Palliative Care, and as you can see, Professor of Neurology and Family and Social Medicine at Albert Einstein College of Medicine. It really is a pleasure to have him. For his current position, he was a founding chairman of the Beth Israel Medical Center Department of Pain Medicine and Palliative Care, the first department of its kind in the country. And he was president of the American Academy of Hospice and Palliative Medicine in 2008 to 2009, and served on their board of directors 2005 to 2009. He's a trustee of the American Board of Hospice and Palliative Care in 1997, since 1997, and was chair in 2006 when the subspecialty status of hospice and palliative medicine was finally approved. He's truly a pioneer in this. In 1986, he became the founding editor-in-chief of the Journal of Pain and Symptom Management, and he continued to serve in this capacity until 2019. He's been elected as one of the 30 visionaries in palliative care by the membership of the American Academy of Hospice and Palliative Medicine, and received the Academy's 2012 Lifetime Achievement Award, the 2020 Gerald H. Hallman Distinguished Service Award, and in 2008, the Project on Death in America Palliative Medicine National Leadership Award. He's recipient of the 2016 Venta Frida Prize for Research from the European Association for Palliative Care, the 2015 Galen Miller Leadership Award, National Hospice and Palliative Care Organization, and the 1998 Wilbert Fordyce Award for Lifetime Excellence in Clinical Investigation in the American Pain Society. Obviously, he's a leader and has been a supportive of interdisciplinary palliative care. So very much looking forward to this talk. Thank you, Dr. Portenoy.
Thanks, Dr. Stone, and thanks for reading that wonderful introduction that I wrote. I think we're about done with the hour, so have a good day. What I'd like to talk to you today about is communication in palliative care, a construct that more recently has been called serious illness discussions. I'll just start by letting you know I don't have any financial disclosures. And let's lay down an important premise that patients with serious chronic illness benefit from repeated, timely, sensitive, and actionable discussions about the patient's or family's perceptions related to the experience of illness. And what I hope to cover today is a workable framework for thinking about serious illness discussions. How can serious illness discussions improve care? And then talk about some pragmatic communication tools that might assist clinicians in developing a higher level of competencies in the delivery of serious discussions. So first, we always start with a definition. How can you define what a serious illness discussion is? Well, one definition says that a serious illness discussion is any communication between health professionals and patients or families which focuses on present or future expectations or preferences about healthcare. The term serious illness discussions is more or less synonymous with a term that's in common use, goal-setting discussions. And it's also important to note that the broader definitions of advanced care planning actually describe the core aspects of these discussions as well. But it's also possible to consider advanced care planning as a subtype of serious illness discussions. And I'll talk more about that distinction in a little while. In 2014, two expert groups, one from the National Academy of Medicine and one from the American College of Physicians, separately wrote white papers and concluded that the US healthcare system needed improvement in the quantity and quality of discussions about goals, values, and care preferences with patients who have serious illnesses. The task force that was established by the American College of Physicians stated that conversations that were more targeted to a period of time when the prognosis of the patient was short, so-called end-of-life conversations, are really important because these are associated with a better quality of life, reduced use of inappropriate life-sustaining treatments near death, earlier hospice referrals, and care that is more consistent with patient preferences. There's also research that was cited showing that patients who engage in advanced care planning conversations are more likely to have their wishes known and followed. and that preparation for the end of life through serious illness discussions is associated with improved bereavement outcomes for the family. So serious illness discussions obviously can refer to conversations or discussions with patients who have serious chronic illness or their families, and could take many different forms and have many different elements. So I want to point out some of the common elements to serious illness discussions, why they are a focus of both research and clinical guidelines. The first is that serious illness discussions generally relate to expectations or preferences about the patient's chronic illness or its management, and that these conversations are typically perceived as potentially inciting distress on the part of the patient or family, because they commonly include either bad news, discussions about end-of-life preferences, or difficult decisions about treatments that may have implications for prognosis. So the assumption on the part of a clinician is that a serious illness conversation may be potentially fraught or challenging because it could incite distress related to information that the patient may not want to hear or may attempt to push back on. It's also true that serious illness conversations tend to elicit clinician discomfort because of uncertainty about the best language and tone to take, the unpredictability of the response of the patient or family, concern or a sense of incompetence in managing a potentially negative response on the part of the patient or family, and also for busy clinicians, just the time required to have these conversations. So given the challenging nature of serious illness discussions and the need to improve them, both their frequency and the competence with which they are conducted, it's useful to think about the approach systematically. What needs to be in place so that serious illness conversations are conducted in a timely way, in a way that generates information and exchanges information with the patient and family that may lead to actions that support the patient's wellness or patient's preparation for serious disease. And I would suggest to you that a systematic approach would first identify appropriate patients at appropriate times for a serious illness conversation. I'd further suggest to you that a systematic approach would actually consider what each conversation was attempting to accomplish, what I would call the specific objectives of the conversation. And then in order to try to reduce variation in practice and improve the quality, you'd want a structured approach to the conversation that could be implemented in real time and then documented subsequently. So from the clinical perspective, let's just talk about this who, what, when framework for thinking about serious illness discussions. Who is the appropriate patient or family? So all patients and families living through any type of serious chronic illness, any chronic, incurable, or progressive, incurable, or life-limiting, or serious or life-threatening illness, all of these very generic terms relate to the same observation that there are chronic illnesses that are not curable, that have the potential for progressing and potentially leading to the death of the patient. Any of those illnesses with any trajectory, whether it's likely or not to progress or become complicated by serious comorbidity, patients with those problems should be considered for serious illness conversations that focus on expectations and preferences. Patients who don't have a single serious illness, but rather have multimorbidity, frailty, advanced age with the potential for geriatric syndromes, all patients of that type should be considered for serious illness conversations. And if all of those populations are appropriate for serious illness conversations, the question is when to have them. And in this regard, we consider the variation in the types of serious illness conversations that may be appropriate and may be useful when taking care of patients with serious illness. So some types of serious illness conversations are appropriate at any time. And I'm going to give you a framework for thinking about those kinds of objectives that may be useful to pursue at any time during the trajectory of illness. For primary care, those types of conversations are now actually being considered part of the annual evaluation. They're being supported in the field as being baked into the annual evaluation of patients who are just coming back for a routine assessment. But some types of serious illness conversations are appropriate when there is recognized progression of disease or new complications. For example, when physical signs indicate that the illness has progressed to a worse stage, or after an event like hospitalization that may indicate that the disease has changed. And finally, there are some conversations that are very important when the clinician recognizes that life expectancy is limited. In other words, the end of life appears to be approaching in the near term. It's very difficult to know how long that is, but typically in the context of declining functional status, those signs suggest that the end of life may be near, and that observation then may trigger serious illness conversations with a specific group of objectives. Now, I keep bringing back this idea that serious illness conversations might be best approached systematically by recognizing that there are multiple objectives that could be pursued in any conversation. Whenever a clinician is planning to discuss a sensitive issue, one or more of these objectives could be considered to be the priority for the clinician. Now, obviously, when a conversation is engaged with the patient or family and the clinician does that thinking that you're going to talk about advanced care planning or you're going to talk about treatment decision-making, the patient or family may take that conversation in a different direction. But at the time that conversation is beginning, the clinician typically has an objective in mind, one or more specific objectives, something that he or she hopes that the conversation will accomplish and may lead to actionable information. And in this regard, one can talk about a framework of objectives that I have called either general objectives or specific objectives. A general objective of a serious illness discussion is to acquire information that may help the clinician better understand the person or family. And a specific objective of a serious illness discussion typically is intended to acquire information that helps the clinician recommend or implement treatment decisions. As you think back to your own experience interacting with patients and families, you'll sense that both types of objectives are very powerful and indeed they could be profound in terms of providing support to that patient or family or helping them articulate preferences and values that are become important during the management of the illness. Getting to know the patient from a general objective perspective, learning who they are, what their preferences might be in terms of healthcare plans that would be implemented for the patient's illness or the support that the family needs, that can be very useful information at any point in the disease trajectory. And a specific objective may be suggested at specific time points, particularly when treatments are needed. And this is the framework that may help you think about these general objectives and specific objectives of serious illness discussions. General objectives could be intended to acquire information about the patient's or family's values and preferences, among which are decisional control preferences, who makes decisions about healthcare, a desire for information preference, more information, less information, a view of trade-offs, quality versus quantity of life, for example, and generic views about treatments that may or may not be necessary in the future. Other general objectives may be characterized as prognostic awareness. Prognostic awareness is the information that the patient and the family is able to articulate about their own understanding concerning the severity of the illness or the extent to which the illness may attenuate life. Also, immediate and long-standing life goals, fears, and concerns. All of these elements, values, preferences, prognostic awareness, life goals, fears, and concerns, I would call the potential general objectives of a serious illness conversation. Specific objectives attempts to acquire information about treatment decisions that probably will be needed soon or actually are on the table for discussion in real time, whether or not to go into the hospital, to go back into the ICU, to start dialysis or discontinue dialysis, to begin artificial ventilation or artificial nutrition, to consider a referral to hospice. Another specific objective could be to engage in a discussion about values and preferences that determine decision-making in the future, a future-facing serious discussion, which you may call advanced care planning. So let me spend a few minutes talking about all of these elements of the framework so that you get a sense of how they're important and how the framework can help a clinician decide on how to structure a conversation so that the outcome leads to information that's timely, important to the patient and family, and potentially actionable. So I noted that the first general objective relates to the patient's values and preferences, the patient or the family. And I noted that under values and preferences, the literature suggests that we could look at this in terms of decisional control preferences, desire for information, view of trade-offs, or views about treatments. Let's talk first about decisional control preferences. Decisional control preferences is a term of art that asks the question, who makes healthcare decisions for the patient? And there has been research, there's been a tool validated to evaluate this. There's been research that has attempted to determine whether patients may be what has been called more active or supporting decision-making by himself or herself versus more passive, where the physician or the family is given the role of decision maker, or shared, a mixed approach. The distinction between active, passive, and shared decision-making preference has been evaluated with the instrument called the Control Preferences Scale. And studies using the Control Preferences Scale have shown this enormous variability in the population. It varies by sociodemographic factors, by culture. It may be different with different types of decisions. It may change over time. Here's an interesting study from 2017 done by our colleagues at MD Anderson Cancer Center. It's a survey of over 1,490 patients with advanced cancer who came from multiple countries. Each bar represents a different country: Argentina, Brazil, Chile, France, India, Singapore, South Africa, Spain, the USA, Philippines, and Jordan. The bottom darker purple is how the Control Preferences Scale indicated a preference for a passive approach where others make decisions for the patient. The lighter purple in the middle is a shared approach representing patients who wanted to have some decisions made by themselves and some decisions made by family members or doctors. And an active, the purple part at the top is the active patients, those whose scores on the Control Preferences Scale indicated that they wanted to make their own decisions. And what you see across this graph are enormous differences by country in the tendency of patients to score different ways on the Control Preferences Scale. And this, of course, reflects differences in culture that permeates a nation, but within a nation, there's often multiple cultures. And the bottom line here is that each individual patient can't have their preferences with respect to decisional control predicted a priori. There's no way of knowing whether a patient is an active, passive, or a shared decision maker. And therefore, the only way to assess this decisional control preferences is by assessing it through direct questioning. And this is a part of the values and preferences related to treatment that should be assessed early and documented. And it should be assessed from time to time because patients may change in how they view how they view decisions being made for them. So this is the kind of question that one could ask a patient when it comes to a decision about an important treatment for your illness. Are you the kind of person who likes to make her own decisions? Or do you rely on your family or your doctor to make the right decision for you? It's so useful to have that question asked, maybe at the annual evaluation or when the consultation with palliative care is first done, because it helps frame how conversations need to happen going forward, especially conversations that focus on treatment decisions. Another value or preference relates to the level of information that the patient or family seeks. Some patients want generally more information about their illness, some want generally less. There's limited empirical literature that suggests that this variation, that this factor also varies, and it varies related to the type of decision, the type of conversation, and also to sociodemographics and culture. For that reason, one is not able to predict a priori how a patient is going to respond with respect to a desire for information. So the only approach that makes sense clinically is to assess this with direct questioning. This is another value, another preference that could be assessed early and repeatedly and then documented. So a question like this one, are you the kind of person who wants to hear the details about your illness? Or do you usually like more general information with details only when the doctor feels that it's really important for you to know? If this kind of question is asked early on in the disease trajectory, or when the patient first gets a consultation from palliative care and then it's documented, it can help frame serious illness discussions going forward. The same is true for the view of trade-offs as a general value. Patients may vary in terms of whether or not they lend highest value to the quantity of life or to the quality of life. They vary in how they judge the burdens of treatment, whether or not a side effect profile is considered a burden, whether or not the cost of treatment is considered to be something that can't be borne or excessive, or whether they don't view those burdens as particularly high and instead focus on efficacy. And how they view efficacy of treatment varies from person to person. Some patients feel that 5% efficacy, they understand that statistic, and that's a chance that they want to take for the possibility of disease control. Other patients don't feel that way. A study of US cancer patients used scenarios and found that there were 3 groups that could be identified using multivariable techniques in terms of their trade-off perspective, and that these groups varied by both socioeconomic status and education. One group had a general priority for survival. Any treatment that could increase the survival from a chronic illness, even by a short time, was prioritized. Some had an aversion to high cost, and some were very averse to toxicity from treatment. And just like the extent to which patients and families want detailed information, or the extent to which they want to have the right to make their own decisions, or they pass that on to others, this is a very individual value, and it can only be evaluated by direct questioning. And this, like the others, might be evaluated early and documented because it can help frame future discussions. A question like, people who have chronic illnesses differ in how they judge what is important. For example, some people say that quality of life is the most important thing, while others say that controlling the disease and living as long as possible is most important. It's often helpful knowing how patients think about these kinds of trade-offs. A general question like that, with documentation of the response, can help inform future discussions with this patient and family. And finally, I always include as an objective, a general objective, trying to elicit views about treatments that may become important in the future. For example, waiting until the patient needs hospitalization to have a discussion about whether or not the patient would prefer to be hospitalized or not is often very challenging, particularly if the patient's in distress. It makes much more sense to proactively consider whether hospitalization or an ICU stay or artificial nutrition or hydration may be necessary in the future, and elicit the values and preferences of the patient and family in advance of the need to make those decisions. So general views about treatments might also be considered as part of that, as part of a discussion that happens at any point in the disease trajectory. And in addition to specific treatments, it's important to consider bringing up hospice early. And I wanted to highlight that because of the common problem we encounter with late referrals to hospice. If hospice was brought up as a healthcare system that provides services when you become eligible, and that's brought up early, concerns could be elicited and dealt with while the patient and family don't have to make a decision about hospice, but only to inform them about it. That may be a way of helping to improve the ability of clinicians to use hospice effectively for end-of-life care. So we're still on the general objectives, and one of the general objectives is to determine what the patient knows about his or her own prognosis. And this is a very important one because many serious illness discussions start off with this. Many serious illness discussions ask the patient, what's your understanding of the disease? And in some respects, that might be just to find out whether or not the specialist had talked to the patient about the status of their cancer, for example. But it can be used in a more generic way to determine whether or not the patient has awareness of the extent to which the disease is serious, advanced, and potentially approaching the end of life. In 2017, a systematic review identified 34 articles focused on studies of prognostic awareness. And these articles generally showed that accurate understanding was had by only half the patients. And in fact, clinicians commonly had misperceptions, believing that the patients knew more than they actually did. In 2015, there was another study of US cancer patients, 590 of them, that showed that only 17.6% recalled having a prognostic discussion. Those who recalled having a prognostic discussion told the investigators that those discussions were not associated with any negative outcomes. In 2016, a study in Taiwan showed that accurate prognostic awareness was not associated with anxiety or depression, but was associated with a higher sense of burden and a lower quality of life. In 2017, another study from Taiwan showed that a large population of cancer patients could be analyzed in terms of prognostic awareness and yield 4 states of awareness: unknown and not wanting to know, unknown but wanting to know, believing that something was known but the information that was articulated was inaccurate, and actually believing that something was known and accurately stating prognosis. Only 59.5% of this group had an accurate awareness, and those patients tended to have a stable categorization in terms of prognosis. They had an accurate awareness that remained accurate over time. So when one looks at the literature on prognostic awareness, the studies suggest that it may or may not be beneficial and it may or may not be desired. Now, obviously, you'd hate to have your evidence base on everything in healthcare be as challenged as that statement, but that's the reality. When it comes to prognostic disclosure, which is what clinicians do to yield prognostic awareness, we're dealing with a situation in which we don't really know whether increasing prognostic awareness as an objective is going to help the patient or family, or whether or not it's something that they want. We also don't know how the patient and family want to deal with what prognosis means to them. Clinicians tend to think about prognosis in terms of time, but patients may think about prognosis either in terms of time or course of illness. For example, time may be discussed in terms of actual days, weeks, months, or it may be discussed with a more generic type of time horizon. You have a terminal illness. But the course of the illness may be described in terms of the symptoms or complications produced by the illness, or the effect of the illness or its treatments on the individual or the family. So one of the challenges in talking about prognostic awareness is that we may be assuming that we're talking about awareness of how much time the patient has left. The patient may be focused on awareness of what's going to be. Will I be able to function? Will I still have access to treatment? Will the treatment make me too sick to function? And without clarifying that, we can try to do prognostic disclosure with information that's really not the type of information that's being prioritized by the patient or family. So prognostic awareness is really challenging. And we also know from at least one study that prognostic awareness is happening all the time, right? Patients are getting information from their primary care physicians, from their specialists, from the internet. They're getting information all the time. And they have states of prognostic awareness that they may not actually even express, and that these states may be either accurate, inaccurate, or the patient may be avoidant of information and not wanting any information, or may not have information and wanting to know. And we don't know which category describes the patient at the time that you're talking to them. So it's challenging, and prognostic awareness, which is really baked into consideration as a best practice in palliative care, really needs to begin with an assessment of the patient's understanding and desire for information. And the understanding is the understanding of how they think about prognosis and what they know about it, and whether what they know is accurate or inaccurate in terms of the known medical information, and whether or not this assessment leads to an understanding that the patient really doesn't want to know, or doesn't know, recognizes that he or she doesn't know, and actually wants information. And with that kind of background, the assessment of the potential for prognostic awareness, that then can lead to a conversation that corrects inaccuracies and provides information to those who want it. So the typical way that serious illness conversations are initiated is to ask, how much do you know about your illness, about how serious it is, or what might occur in the future? When patients begin to describe this, some additional questions might provide a much better understanding about whether or not the patient has accurate information, wants more information, and if they want more information, is that information about the course of illness or their time? Some patients benefit from having more information about what to expect. Some want to know more about their prognosis. Do you feel the need for this information? What's the most important question for you right now? So serious illness conversations that sort of begin with this humility, this understanding that we don't really know how a patient is processing the reality of living with chronic progressive illness, and whether or not information about prognosis is viewed by the patient as supporting their ability to adapt to that illness or not, and what information related to prognosis would support adaptation and to illness. Without knowing that, and we don't know that, the best way we can begin is through an assessment that provides that information enough so that we can know about prognostic disclosure. Finally, the general objectives beyond the ones I've talked about are parts of a conversation that often happen when the patient is not imminently deciding about a treatment, is not very ill, but and these are very important values and preferences that might relate to life goals, expressed fears and concerns. Some patients experience benefit by sharing information about their near-term goals, things that have not been done and may still be possible, or talking about past events or milestones, memories that bring joy, connectedness, or meaning, a life review process, or discussing legacy, what would be remembered after you're gone. Talking about these goals is therapeutic for some patients. So this is sort of an important insight, that the time that a clinician takes to discuss life goals, either in terms of things that still want to be done, things that have been done, or things you want to leave behind, those conversations can themselves be perceived by patients as supporting them, their ability to adapt to illness, their ability to remain engaged with others in their family and outside of their family. And finally, sometimes it's just important to ask patients directly whether they have fears or concerns. And this may elicit information that can be dealt with in real time and potentially prevent those from worsening. So assessing life goals or fears or concerns also need to be assessed with direct questioning. This is the theme of serious illness conversations. A lot is empathic listening, but that empathic listening needs to be elicited by questioning that allows the patient to have a framework for responding and providing information that addresses these objectives. You might say to the patient, given how things have been going during the past few months, it wouldn't be surprising if you were having some concerns or even fears about your illness or the treatments that we are using. Tell me, what are your concerns? So serious illness conversations can be framed in terms of these general objectives, or the clinician may decide before engaging a patient in a serious illness conversation that the priority would be to get quite specific about a treatment decision that's imminent or about advanced care planning. A serious illness discussion about a specific treatment is typically needed when the patient needs to consent to that treatment, or the service or treatment the patient needs to be organized. And discussing those preferences with respect to specific treatment allows the clinician to understand whether or not the treatments or services align with the patient's values or preferences as they are understood. It may suggest that there's information that's not understood by the patient or family about a treatment or about a service like hospice, for example, and that providing that information may reduce anxiety or increase the openness of the patient and family to accept that care. You might get information about the way the patient frames this treatment in terms of risk or burden or trade-offs, and the way the patient views efficacy or effectiveness. In other words, if the patient is being offered a treatment because the clinician knows the data, and it is more likely than not that the patient may have a positive outcome, which may be defined in terms of a very specific type of set of outcomes, the patient may view that in a different way. Patients may view the outcomes of importance in terms of functional status, in terms of the ability to interact cognitively, in terms of mood response, in terms of being able to do something specific like eat again, and those outcomes may or may not be concordant with the outcomes that are driving the clinician's recommendation to institute a treatment. So understanding how the patient views effectiveness, understanding how the patient judges risk or burden, the extent that they understand that, making sure that the patient's information is factually correct. Those are all elements of a serious illness discussion that focuses on a specific treatment. And advanced care planning can be viewed in the same way. As I mentioned before, some of the literature on advanced care planning really defines the core elements to overlap very extensively with the definition of a serious illness conversation. And I'm comfortable with that. If you are engaging in serious illness discussions, but you're calling them advanced care planning, if the advanced care planning conversation has objectives to evaluate the values and preferences of the patient in terms of decisional control preferences, or in terms of the level of information desire, or to elicit information about goals, fears, concerns, or prognostic awareness, that's all fine. However, you could define advanced care planning more narrowly and say that it is a communication between health professionals and patients or families, which may clarify values and preferences for care or address prognosis or other concerns, but more specifically plans for the healthcare that will be received in the future if the patient becomes incapable of communication. Advanced care planning, in other words, has a component of future-facing discussion in which the patient is asked to imagine a situation in which he or she cannot express preferences for care, and therefore they are being given an opportunity when they have sentience, when they're able to express preferences, they're given an opportunity to say, what would you want in that event? Advanced care planning has one key objective by itself, and that is to create a legal and actionable advance directive. Now, the newer literature on advanced care planning emphasizes the importance of not thinking that an advance directive is advanced care planning. And that's fair enough. I agree with that. But I also think it's important to say that in our current healthcare system, the goal of an advanced care planning conversation must include an advanced directive, because an advanced directive is the tool by which the patient's values and preferences expressed now can be operationalized when they no longer have the ability to express their own views. And there are two kinds of advanced directives. One advanced type of advanced directives selects a person who can speak for the patient. That's called a durable power of attorney for health decisions. And the paper on which that's written is called the healthcare proxy. Or an advanced directive can give instructions about future care preferences, and that's called an instructional directive, and includes oral or written living wills, non-hospital DNRs, and a medical order for life-sustaining therapy or POLST. Advanced care planning accomplishes a lot. A 2014 systematic review of 45 studies showed that decreased hospitalization could be documented in 2 of these studies. Decreased inappropriate life-sustaining therapy was documented in almost half these studies. Increased referral to hospice or palliative care was documented in 5 of 7 studies. A 2017 systematic review of 16 studies found that advanced care planning does increase the congruence between what the patient says the patient wants and what the surrogate knows later that the patient said. But this was limited to Caucasian. There was actually little evidence in the literature that concordance between patient and surrogate was improved in minorities. So this represents still a need for more research and determination of whether or not different strategies for advanced care planning need to be created in order to meet those needs in racial and ethnic minorities. There's still limited evidence that the care that a patient who has completed an advanced care plan actually gets is consistent with the patient's values and preferences expressed during the advanced care planning phase. That evidence is hard to acquire, and it still remains to be determined in research. So the best evidence for advanced care planning is that it improves the likelihood that someone will be available to speak for the patient in the future, and that the care provided in the future will reflect the patient's preferences. What's the best type of advanced directive? That's open to interpretation. To express my own view to you, I think the best type of advanced directive is the one that's most flexible and useful in different contexts, and that would be the healthcare proxy. That would be when a sentient adult selects an agent to speak for the patient in the event that the patient is incapable of speaking for himself or herself, and the agent should know what the patient's values and preferences are. That to me is the most useful model, but obviously some clinicians really prefer a model that's incorporated into the medical orders for life-sustaining therapy, for example. What's the best approach to advanced care planning? I think it's now generally agreed in at least medical practice that ACP should be incorporated early into the care of patients with chronic serious illness and then revisited periodically, particularly after major healthcare events. So I talked to you about the definition of serious illness discussions and when they might be considered and in what populations. And I suggested to you that serious illness discussions can be made perhaps more effective by having a framework for thinking about the topic that needs to be discussed in real time. In other words, clinicians go in to talk to a patient or family. They are expecting that the time is right to engage the patient and family in a discussion that relates to values and preferences, treatment decisions, other information that could potentially be challenging, could potentially lead to distress. There's often clinicians often feel some discomfort when they walk into the room, not knowing how the patient's going to react to the information that needs to be prioritized, not knowing how long the conversation is going to take place. And I've submitted to you that an approach to dealing with all of that uncertainty, all of those challenges, is to have a framework in which the clinician considers what the objectives of a serious illness conversation might be, whether they're general objectives to learn about the patient and family, or they're specific objectives focused on specific treatments, and to have those objectives in mind when the patient and family are engaged in a conversation. What then becomes necessary is a systematic approach to communication something that allows this engagement to be done in a way that's likely to yield a positive outcome. And you probably know that there have been many studies of communication tools that have been developed either for assisting clinicians in breaking bad news or undertaking serious illness discussions of a variety of types. The SPIKES protocol has been around for a very long time and is a protocol for delivering bad news. More recently, a group at Mass General in Ariadne Labs put together a serious illness conversation guide, and they've done some very nice research showing the value of the guide in training physicians to have serious illness discussions that are meaningful. Vital Talk has been around for a very long time and provides a simple approach for serious illness discussions. And I will share with you a model that we use here at my place. We've developed it to train our fellows and our nurses. We call it the Opus model. All of these approaches have common elements. We created the Opus model because we were looking for something that was relatively easy to embrace, to use with different disciplines as exist in our healthcare entity here. And we're using the Opus model, trying to learn about it and seeing whether it's useful. The key concept here is that serious illness discussions are iterative, may focus on an array of issues. The conversation involves preparing on the part of the clinician to know what objectives will be pursued, and then the engagement of the patient in the discussion should be structured using elements that have been incorporated into all of these communication skills trainings. Our model called Opus puts those elements into a mnemonic, which stands for opener, permission, understanding, and support. Our Opus model says that engaging the patient first requires setting the stage, making a neutral opening statement about a desire to have a conversation about the patient's illness, and then expressing what the main objective is in general terms to see whether or not the patient is interested in having this conversation now. But the immediate segue is to a permission phase, and all of the communication skills trainings have this. The permission phase asks specifically of the patient, is it okay to proceed now? And do we have the right people in the room? The patient may say, I'm not really interested in this right now, or they may say, well, this sounds good, but I want to have my wife present. So it makes sense to have a conversation only when the patient has openly accepted that engagement and when the patient has given the information about who should be in the room with them. Finally, once permission has been granted, the U in the Opus model stands for understanding, and that's summarized in 4 questions. It starts off with that general question about prognosis, but in a very generic way. What does the patient and family know about their illness right now in terms of its severity, its likely course going forward in terms of the availability of treatments? That then typically leads to some questions in order to elicit additional information. And then the important segue to the objective. The physician or the nurse, the social worker who's having this conversation has an objective in mind. This hopefully would be the point at which that objective could be realized by providing information to the patient that is specific and allows the objective to be pursued. And then after that information is provided, asking the patient what more they want to know. Sometimes this kind of dialogue produces distress, and so it's important to ensure that the patient is allowed to express emotion. The principles of empathic communication are followed so that the patient has an opportunity to have a sort of empathic response that allows them to process what they're feeling at that moment. And then typically, the clinician has a plan in mind. That plan could be for another conversation, or it could be for additional information, or if this model is being used in order to get a treatment decision, the plan may be how we're going to go forward with respect to hospitalizing you, or with respect to providing artificial nutrition. So let me just spend very briefly deconstructing this a little bit. In our Opus model, the opener covers setting the stage and offering a neutral opening statement. For example, I would like to talk to you about your illness. You and your family are dealing with many problems, and I want to understand what you know about your illness, answer questions you may have, and talk about how to get you the services you need. The permission statement, very simple. Is it okay to have this discussion now, or would you want someone else in the family to be here? The understanding question, the understanding component of the Opus model. What does the patient know? What else should be elicited about that? What information should the clinician provide? And what more does the patient want to know? Or what else do they need with respect to that provided information? An approach to that it tends to be preferred in speaking to patients who of a variety of different cultures and levels of understanding is the so-called ask, tell, ask technique, giving information in short sentences without jargon, repeatedly stopping and asking the individual if he or she understands or has questions, and then periodically asking the individual to repeat a key point and correct any misunderstandings. And clinicians may value having some key phrases that help them impart challenging news, like hope, worry statements. You know, we want to hope for the best, but I'm worried that your disease may progress and you're going to be spending more and more time in bed. So we need to talk about what happens next. Or hope for the best, prepare for the worst statements. I hope you don't need to go back in the hospital again. The last time, however, was a pretty challenging hospitalization. We need to prepare for that just in case it would occur. Is going back into the hospital something that you want to do? So hope, worry statements, hope for the best, prepare for the worst. These are approaches to build into communications that can provide this dialogue to the patient where issues are being assessed and information is being provided. One of the examples for this might be related to hospice. Again, hospice could be presented under the general objectives when the patient is not hospice eligible, but is moving toward that. And you have the time to go in and talk about this program, knowing that if you provide information now, when the program is presented to the patient in the future, that may occur with less anxiety, that may occur with a greater willingness to accept a program that could provide support that the patient and family needs. So you might talk to the patient by saying, your doctor says that you are probably eligible for the hospice benefit. It can offer services at no cost to you. Can I give you more information or send a nurse out to talk to you about hospice? I'm going to just jump ahead here for time. And then finally, the last element of Opus, after the opener, the permission statement, the understanding dialogue, is to provide support. And again, the goals here are to allow emotion, to empathize, and offer a plan. Sometimes that hospice conversation, particularly when it's being done with the specific intent of determining whether or not the patient is interested in enrolling, can generate a great deal of anxiety, sometimes negativity or avoidant behaviors. And it may be useful to say something like, I know that hearing about hospice sometimes raises concerns and it's okay to be upset. You don't need to make a decision about hospice right now, but I would like your permission to refer you to the program so that they can speak to you or send you to a nurse here to discuss it. You don't have to accept the program after hearing about it. So what I try to talk to you about today is this very broad topic of serious illness discussions, pointing out that serious illness discussions are a core practice in palliative care, and they have and the models for thinking about serious illness discussion have been evolving for decades as research into the various components of serious illness discussions has been conducted. I try to suggest to you that if you think about it in terms of a who and when model, and then a what that incorporates thinking about this framework of objectives, you might be able to structure serious illness discussions over the course of an illness in a way that allows them to be both timely and effective and potentially actionable in terms of the types of treatment decisions that need to be made during chronic serious illness. And I suggested to you that thinking about the objectives of these discussions, it may be useful to distinguish those that are intended to learn more about the patient and family. So discussions about values and preferences, about prognostic awareness, about future-facing treatments, about goals, fears, and concerns, and to distinguish those general objectives from very specific objectives when the point of the discussion is to determine whether or not a treatment should be given or determine whether or not an advanced directive needs to be completed or amended. And by thinking in terms of these objectives, the serious illness discussion can be engaged with the patient and family with goals in mind on the part of the clinician. Now, these goals may not be accomplished. It's possible that the conversation will go in a completely different direction, but it would likely increase the potential for these conversations to lead to outcomes that would support the patient's healthcare and support the approach to healthcare that would allow the patient's values and preferences to inform treatments in a more meaningful way. And this engagement using that objectives framework typically requires a communication strategy, and there have been many published. I suggested one to you today that we developed called the Opus model, but this is just another type of communication skills approach that focuses on how to engage the patient, ask permission, have a dialogue about the important issues, and support the patient as this is unfolding. Serious illness discussions are a core practice, and the processes that I've discussed with you today hopefully improve communication and the outcomes of these discussions in a way that supports the healthcare goals of the patient's family and the system. Thank you.
Dr. Portenoy, thank you so much. It was really, really great. We don't have a lot of time, but there are a few questions that maybe we can get to, and Craig has appreciated it and put everybody to a recent JAMA Viewpoint article by Morrison, Meyer, and Arnold. But Margaret McDonald from Visiting Nurse Services says, what's known about how often or to the extent that preferences change over time as the disease progresses?
Yeah, so there have been studies that have looked at that, and some of the studies, in fact, have used very sophisticated statistical modeling approaches to show the extent of change, the likelihood that change occurs. So I can't summarize for you a probability or a risk, and what I would emphasize in this kind of discussion is that from a clinical perspective, it's a reality. So we know that preferences change. We know that preferences change sometimes quite acutely, sometimes in relation to an event that occurs or a new family member who expresses an opinion. So clinically, knowing that change occurs and that the change can be very substantial informs this process of serious illness discussions. It basically gives us that humility to say, well, I think I know what this person wants and who this person is, but in the last 2 months that might have changed. I'm going to ask again. And that's my approach to it.
Thank you. There's one other question from Kate Barron. She says, is there a specific gap in the education conversations with patients that you think would benefit from more research, specific types of diagnoses, populations?
Oh yeah, I'm not usually shy or that limited in saying that more research is needed about everything. I mean, I think you saw, I try to summarize some of the research. It's overwhelmingly observational research. A lot of it is not even longitudinal. A lot of the research does not use sophisticated statistical modeling approaches to try to understand factors that may influence outcomes or cluster. The impact of culture, of race, ethnicity, of educational level, of socioeconomic status, I think we know very little about that in a diverse society like ours. So I think, you can't force me to pick only one thing. I'm not going to. I think one of the things I really love about palliative care, to be honest with you, as a person who does research, is that this field is still in a place that high value survey research, high value observational research, high value qualitative research is all going to contribute enormously to the field. And so everybody can do research if you sort of get the team together and you try to do it in a high quality way, you can make a big contribution because the gaps are so enormous. We're very young as a field. 1977 was the first time that the word palliative care was used.
Yeah, that's amazing. Craig has a question or comment.
Yeah, hi Russ. First of all,
Hi.
Thank you so much once again for a terrific talk. Just going to sort of summarize the question I put in the chat box, just to kind of put it out there. I've been skeptical, as I think a number of us have been, of the enormous educational and energy that is spent on trying to train primary care providers and others in the fields outside of palliative care, outside of specialist level palliative care, to have these kinds of, as what we're calling advanced care planning conversations, as differentiating them, as you did as well, from serious illness or goals of care conversations that might be related to an ongoing or a specific issue. And sort of this idea of sort of thinking into the future, all of the challenges that entails, looking at hypotheticals, trying to construct, and all the things that you mentioned and it's been pointed out. And in this recent JAMA article, and I think in another piece that was out in Journal of Palliative Medicine, Sean also had pointed out some of these, the lack of evidence, or at least the limited evidence that we do have for outcomes that we care about. And as you mentioned, yes, there's a problem with some of the quality of the studies and so on. But he makes an interesting point, and I wonder what you think about this. Rather than to just counter what you just said before, rather than spending even more energy, resources, and research investments in continuing to dig at and excavate this issue of advanced care planning, especially in primary care places, might we just be better off just improving palliative care or doing some other thing with our time than continue to try to figure out what's the best way to do advanced care planning? I mean, we have the serious illness checklist, we have, all of these things that you mentioned, and they had a negative study just recently, a few years back, as you know. And so, I'm a little skeptical. I think we do it well. I think if we follow a framework that you set up either with Opus or we have, trained fellows and palliative care clinicians who are doing this, I think we do a superb job. I don't trust, or I don't think that it's worth the effort or energy for everybody to do this. And I'm curious your thoughts about that.
Yeah, that's a really astute question. And I have actually spent some time thinking about this as well. And, I got some subtle criticism because I implied at some point that advanced care planning was sort of an easy way out, because it's hard to talk about the here and now, but if you put everything in the future and make it hypothetical, it's a lot easier. And so teaching people how to do advanced care planning discussions was, in that opinion, sort of quasi serious illness discussions. And one of the reasons why there was a lot of bad advanced care planning going on, because the people doing it didn't have the skills, didn't understand the framework, and really were looking to get an advanced directive as quickly as possible. It brings to mind, I had this experience in a large community-based practice. I was talking to them about serious illness discussions and palliative care, and the leader said that she was very proud of the practice because they had started an advanced care planning program and to improve that in the practice, thousands of patients. And I said, what was the program? And they said, every patient coming through the door gets an advanced directive. And I said, and then what? And she said, what do you mean, then what? And I thought to myself, boy, that was, in a nutshell. So I think the question for me, Craig, I guess is do you let the perfect be the enemy of the good? Or is there a good that you could preserve and recognize that you are very far from perfect? And that's the challenge, because we know, clinical experience suggests that conversations can be so profoundly therapeutic. I'm sure that's been your experience 1,000 times, where you might have walked away from a patient family not even realizing that you were doing anything except a little information sharing, but you had a profound therapeutic impact on that patient and family. And I'm a little reluctant to sort of say, let's not invest in this anymore because the outcomes are unknown and so many people are doing it poorly, when we know that if you can get some of them to do it better, the therapeutic impact, the impact on the quality of life, the reduction of illness burden can be huge. That's what I struggle with, but I do think one of the things you bring up, and I'll just say this is the last thing, and I really, and you're great at this, by the way, is we got to be more honest. If it's not work, when I was talking to that leader of that huge practice, I started laughing uncontrollably. That probably wasn't very, wasn't very kind of me. And she said, and then when I was laughing, then she started laughing, and she said, "You're laughing because we don't really know if we have a program." And I said, "Exactly." And, but that had been going on a whole year. They had wasted a whole year on a program they thought was advanced care planning by literally throwing pieces of paper at people in the waiting room. And so maybe that got better, by being honest. I don't know. That's not a great answer. I'm sorry, but you raised a tough one.
No, the very first question I wrote down is how are primary care providers trained? You said this was baked in annual assessments, and it just seems like in the community we need the training. It's interdisciplinary, and yeah, I think we need a lot more research on how to do it best, as well as getting clinicians trained as good as we can. We are over time, so I just want to quickly, and I really cannot thank you enough. This has been absolutely terrific. Thank you very, very much.
My pleasure, really. Thank you all for coming and listening. It's great to see you.
Yeah, I want to remind everybody we're not having in November because of the November holidays. Our next enrichment will be in December, and it is Bridget, help me here. I've got it from Emory, a palliative care researcher.
Gotcha. Mi Kyung Song. I think Russ, because you're sharing, I can't share just yet, and that's all good.
Well, I'll stop.
Okay. Thank you.
Thank you. In fact, I'm going to jump off. Goodbye, everybody.
Thank you so much for your time. Thank you. So our next one is, Dr. Mi Kung Song from Emory. She directs the Center for Nursing Excellence in Palliative Care. She's a well-known nurse scientist in this area. So we look forward to doing that on December 9th. Everybody, in the meantime, have a happy fall, and we'll gather again in December. And thank you for your time. I thought this was really an excellent presentation, so I hope you did too. Take care.